Hey everyone, welcome back for another deep dive.
Always a pleasure.
So today we're going to be diving into the 2023 Practitioner's Toolkit for Managing Menopause.
Yeah.
It's a publication that was endorsed by all the major international menopause societies.
It's a great toolkit.
Really seems to be like the new gold standard for, current guidance for managing menopause.
Yes,
So
really.
I thought this would be a really relevant topic to cover for our listeners, especially since, a lot of endocrinologists are seeing a lot of patients coming in with,
Oh, absolutely. This is bread and butter for us.
bread and butter,
Yeah.
menopause management. And so,
Yeah. So, the toolkit really gets back to basics. And I think it's really important to highlight that because it clarifies some key definitions.
well, for sure, for sure.
So we're all on the same page.
Yeah.
When we're talking about, the different stages of this transition.
Yeah.
So menopause itself, as we all know, is defined as the permanent cessation of menstruation.
Right.
But it's not always a clear-cut event. Right.
And that's where some of the, I think, the confusion or the sort of gray areas come in. And so the toolkit, I think, does a really good job of sort of teasing those apart.
Yeah. Yeah, I think, when we're talking to patients, it can get really confusing because, are we talking about perimenopause or postmenopause? Like
yes.
all these different terms?
Exactly. And I think women themselves, they may use these terms interchangeably, or they may not even know the distinction between them.
Right.
And so I think it's really important for us as clinicians to, make sure that we're using the correct terminology.
Yeah.
And that our patients understand what we're talking about.
And just to clarify, for our listeners, perimenopause is that transitional phase leading up to menopause. And then postmenopause is after that final menstrual period.
Yes.
It's everything after.
Exactly.
Got it. Okay, so the toolkit helps us really understand that whole progression.
Yeah, and it actually uses a specific staging system. I don't know if you're familiar with this.
Yeah, the straw plus 10 staging system.
Yep.
Have you used that in your practice?
I haven't fully integrated it yet, but I've definitely seen it, and I really like how it, kind of breaks it down.
Yeah, it's really helpful.
Based on the menstrual cycle.
Exactly. It's all based on menstrual cycle characteristics, and so it can help us really pinpoint where a woman is in her menopause journey.
Right. So it's not just about, okay, did she have her last period or not?
Exactly.
It's like,
about the whole...
what's going on with her cycle? How frequent are they irregular,
Right. How long has it been since her last period? Are her periods getting closer together or further apart? All of that is taken into account.
And they even have a modified table in there.
Yes, they do. They have a modified table. It's very easy to reference.
Very nice.
Very nice.
I actually have it bookmarked.
Me too. Me too. Okay, so we've got natural menopause now.
Yes.
What about surgical menopause? Ah, yes, surgical menopause. So that's another, important distinction to make because surgical menopause, as you know, happens when the ovaries are surgically removed.
Right.
And so it's not a natural process.
Right.
It's induced by a surgical procedure. And so the hormonal changes are much more abrupt.
Yeah, they're very sudden.
Yeah, exactly.
For these patients.
And so women who undergo surgical menopause often experience more intense symptoms.
Yeah, I see a lot of those patients in my practice who
Right.
have had, hysterectomies or oophorectomies, and they have a much more difficult time.
Yeah, it can be really challenging.
Adjusting to those changes.
Absolutely.
Okay, so we've got our definitions down.
Yeah.
What are some other things that you think?
Well, one of the things that I think is so fascinating about menopause is just the sheer variability of the experience.
Oh, totally.
You have some women who sail through it with barely a hot flash, and then you have others who are, really struggling with the debilitating symptoms that affect their quality of life. Their sleep, their mood, their relationships, their work. It can be really, really challenging for some women.
And it can be so hard to predict who's going to have a really hard time and who's going to
Exactly.
not even notice it.
We don't have a crystal ball, unfortunately.
Yeah, unfortunately not.
But, I think that's one of the things that makes menopause management so interesting.
Yeah.
And challenging.
And also, I think, one thing that the toolkit mentions is that menopause isn't just a Western phenomenon.
Yes.
There's this misconception that, it's just women in developed countries who experience these things.
Right.
But the toolkit highlights that research shows that vasomotor symptoms like hot flashes are prevalent globally.
Absolutely.
But there are some differences in terms of, certain symptoms being more prominent in certain regions.
Yeah.
Like, for example, in Asia, musculoskeletal pain seems to be more common.
Right. More so than the hot flashes.
Interesting.
Yeah. So it's not just a one-size-fits-all, kind of experience.
Oh.
It really varies across cultures and individuals.
That's a really good point to keep in mind.
And it also, I think, it debunks this myth that menopause is just about estrogen deficiency,
Oh, yeah.
right?
It's more
Because
complicated than that.
it is more complicated than that.
Right.
The symptoms that women experience during menopause can actually be due to fluctuating estrogen levels. So it could be estrogen excess
Oh,
or insufficiency,
okay.
or even a mix of both.
Wow, I hadn't thought about that.
Yeah, so it's not just about the estrogen being gone, it's
Right.
about this sort of hormonal dance.
It's about the fluctuations.
Exactly.
Okay, so we kind of got a better sense now of like what menopause is and,
Yeah.
how it
Yeah.
varies for different women and in different cultures.
Right.
So now I think the next question is,
How do we diagnose it?
yes, how do we diagnose it? Because, sometimes it can be
Yeah.
pretty straightforward, but sometimes
Right.
not so much.
Not so much. And the toolkit does a great job, I think, of addressing those more challenging scenarios.
Oh, good. Okay, so for most women
Yeah.
over 45
Right.
who have stopped menstruating for 12 months or more,
Yep.
the diagnosis is pretty,
Straightforward.
yeah, straightforward.
They have the symptoms, they've stopped having periods for a year. It's pretty clear cut.
But then you have the cases where,
Yeah, like what happens if a woman has had a hysterectomy,
right,
or endometrial ablation?
okay,
Then there's no menstrual bleeding to track.
right.
So how do you know when they've gone through menopause?
Or if they're on hormonal contraception.
Right. Or if they're on hormonal contraception that can mask the symptoms.
Right.
They may not experience those typical menopausal symptoms because they're on the pill or they have a hormonal IUD.
Okay, so the toolkit helps us sort of
It does. It provides some really helpful guidance.
navigate these trickier situations.
It does. It has a revised diagnostic algorithm that's really helpful. So,
Okay.
for example, it now classifies women over 58 as postmenopausal,
Okay.
regardless of symptoms. And this is reflecting, I think, the trend that we're seeing of a rising average age of menopause.
Okay, so age is playing a more,
Age is becoming a more important factor
yeah.
in the diagnostic process.
So I guess that makes sense if women are
Right.
having their last period later. Then
Exactly.
58 is a
Yeah.
pretty reasonable cutoff.
Reasonable cutoff.
Yeah.
And, another area where the toolkit provides some clear guidance is around hormone testing.
Okay, hormone testing. Let's talk
Yeah.
about that because I think there's a lot of confusion about when to test, when not to test.
Right. And so the toolkit really emphasizes that routine hormone testing isn't typically needed for women over 45 who have those classic symptoms.
Okay.
If they're having hot flashes, night sweats, they've stopped having periods for a year, you don't necessarily need to do a blood test.
Got it. So it can be a clinical diagnosis
Exactly.
in those cases.
In those straightforward cases,
Right.
you can make the diagnosis clinically.
And it also specifically mentions that testosterone measurements
Yes.
should not be used to diagnose
Testosterone deficiency.
testosterone deficiency.
Yes.
So why is that?
Yeah, that's a common misconception, I think.
Okay.
A lot of people think that, if a woman is having symptoms of low libido or fatigue or, any of those sort of vague symptoms that we associate with testosterone deficiency, that we should just check a testosterone level.
Right.
But the reality is that testosterone levels fluctuate significantly in women.
Okay.
And so a single blood test isn't always a reliable indicator of true deficiency.
Okay, so we should be very careful about just
Exactly.
ordering these tests willy-nilly.
We need to be judicious with our testing
Okay.
and really consider the clinical context.
Got it. So basically,
Right.
don't just order the tests
Right.
because the patient's asking for it, or you
Right.
think, oh, maybe it could be this. Like, really think about it.
Right. And reserve testosterone testing for specific situations. If there's a suspicion of an underlying medical condition,
Right.
like an adrenal tumor or a pituitary tumor or something like that,
Okay.
then it would be appropriate to check a testosterone level, but not just for,
Not for the
well,
general
that's not-
symptoms of
yeah.
menopause.
Got it. All right. So we've covered definition,
Yes.
diagnosis.
Yes.
Now I think the next thing we have to talk about is,
Management.
yes, management, because that's what everybody really wants to know about.
Right. How do we actually help these women who are struggling with symptoms?
Exactly.
And the toolkit does a fantastic job, I think, of providing a really comprehensive overview of both hormonal and non-hormonal
Oh, nice.
treatment option.
Okay, so they've got the whole spectrum covered.
They do.
And I know there's been a lot of talk recently about
Yeah.
new guidance and things like
Mm,
that on hormone therapy,
absolutely.
MHT.
Yeah.
So let's dive into that because I know that that can be
Yes, it can be a
a really complex area. Absolutely.
And a lot of our listeners, I'm sure, are really interested in hearing about the latest
Yeah.
recommendation.
Yeah, absolutely.
Before we get into the specifics, though,
Yeah.
I think it's really important to emphasize what the toolkit highlights, which is that
Shared decision making
shared decision-making is key.
is paramount.
Yeah.
You know, we really need to tailor the treatment to each individual patient's needs and preferences.
Right. It's not one size fits all.
Not one size fits.
It's really about understanding the patient and what their goals are and what
their concerns are.
what their concerns are and really working together
Exactly.
to come up with the best plan.
And the toolkit does a fantastic job of, really sort of breaking down the different types of hormone therapy, the benefits, the risks, and how to personalize the approach.
Okay.
It covers everything from estrogen and progestogen types to routes of administration.
Okay.
So it's really like,
Like a toolbox.
it is like a toolbox.
For MHT.
Exactly.
That's a good way to think about it.
And it gives you all the different tools that you can use.
Right.
And then you choose the right tool for the right patient.
Okay. So it really kind of demystifies it a little bit
I think it does.
and makes it less scary for
I-
clinicians to actually prescribe
Yeah.
these medications.
Because I think there's a lot of fear out there
Yeah.
about hormone therapy. And, we've talked about this before, but,
Right.
the data really supports the safety and efficacy of hormone therapy
When it's used appropriately.
when it's used appropriately.
And so I think the toolkit does a good job of sort of reassuring clinicians that, this is a valid option
It's a valid option.
for many women.
And it doesn't shy away from those trickier areas like, managing side effects.
Okay, let's talk about side effects because I think that that's
Yeah.
a big concern.
Yeah. And so the toolkit, really emphasizes starting with low doses to minimize side effects. And it provides some really practical tips for addressing those common side effects like nausea,
Right.
breast tenderness, breakthrough bleeding, mood changes. And I think one thing that's really important to remember is that, with hormone therapy, we're not just talking about systemic therapy.
Right.
We also have local therapy options for women who are experiencing urogenital atrophy.
Yeah. I think a lot of women don't even realize that.
Yeah.
That's something that can be treated.
Right. And it's often undertreated.
Yeah.
And the toolkit does a good job of reminding us that, this is something we need to be asking our patients about.
Right.
And that there are effective treatments available. And one thing that's, I think, really reassuring for both clinicians and patients is that, with local estrogen therapy for urogenital atrophy, progestogen is not necessary.
Right. You don't have to.
You don't have to add the progestogen.
Worry about that.
Exactly. And so that can be a relief, I think, for a lot of women who are concerned about the potential side effects of progestogen. But the toolkit also emphasizes that, local therapy needs to be ongoing.
Okay.
It's not just a one-time treatment. You need to continue using it to maintain the benefits.
Okay. So once you start it, you got
to keep going.
keep going.
Yeah.
Now, in terms of, starting hormone therapy, I think a lot of clinicians are wondering, okay,
Yeah.
what kind of follow-up
Right.
monitoring do I need to do? Like, how do I know if it's working or not working?
So the toolkit actually provides some specific recommendations around follow-up and monitoring. And I think this is really helpful because it gives us a framework to work with.
Oh, good.
So they recommend an initial review at 3 months
Okay.
after starting hormone therapy.
Okay.
And the purpose of this review is to assess symptom relief,
Okay.
manage any side effects that might have come up, address any patient concerns, make sure that they're using the therapy correctly,
Right.
all of that.
So just making sure everything's going okay.
Exactly.
And then after that, they recommend yearly follow-up.
Yearly follow-up.
Okay.
And the purpose of that is, to update the medical history,
Yeah.
do an examination, do any tailored investigations that might be indicated.
Got it.
And of course, if the patient has any unscheduled bleeding or any other concerns,
Right.
then they should be seen sooner.
Yeah. Okay. So there's like a clear plan for
There's a clear plan.
follow-up.
Yes,
That's really helpful, I think,
I think so too.
for our listeners, because I know that a lot of times it can feel like, oh my gosh, I started this patient on hormone therapy and now I don't know what to do next.
What to do next.
But this kind of gives us a roadmap.
Yeah, I think it does.
Okay.
It gives us a roadmap.
Perfect. All right. So we've talked about, definition, diagnosis, and management of menopause. But
Yeah.
there's one more really important thing
Yes, there is.
that I think we need to cover.
And that's preventing fragility fractures.
Yes, because this is a major concern for our patients.
Absolutely.
And it's something that I think a lot of times
Right.
doesn't get enough attention.
We don't think about it until it's too late.
Yeah, we're so focused on like, okay, let's get rid of the hot flashes and the night sweats, but we forget about the bones.
The bones.
Right.
And the toolkit really does a good job, I think, of emphasizing the importance of bone health
Okay.
in the context of menopause management.
So let's dive into
Yes.
the toolkit's insights on
Yes.
fracture prevention.
So the toolkit kind of challenges some conventional thinking when it comes to fragility fractures.
Okay.
We often think that fragility fractures only happen in women with osteoporosis,
Right.
but the toolkit highlights that most fragility fractures actually occur in women with osteopenia or even normal bone mineral density.
Really? So it's not
But
just
that's not just about osteoporosis.
the women with like severe osteoporosis.
Exactly.
Wow. Yeah.
So that kind of shifts our perspective a little bit on who's truly at risk.
It does, because I think
Yeah.
a lot of times we think, okay, if the patient's got osteopenia, we don't really have to worry too much.
Right.
But this is saying that.
This is saying that we need to pay attention.
Yeah, we need to be paying attention to these women.
Even those with normal BMD
Wow.
can still have fragility fractures.
And I guess this also kind of underscores why tools like FRAX, which
Yeah.
we often use to assess fracture risk, can be limited,
Absolutely.
especially in younger postmenopausal women.
Especially under 65.
Under 65, okay.
Yeah, FRAX doesn't really account for things like menopausal status or hormone therapy use.
Oh, okay. So it could
As it
underestimate.
can underestimate fracture risk.
Got it. Okay, so if FRAX is not always the best tool
Right.
in those cases,
What do we do?
yeah, what do we do? How do we accurately assess fracture risk in these younger patients?
Well, the toolkit brings in some insights from other studies that I think can really help inform our approach.
Okay.
So, for example, it points to the 2023 American College of Physicians recommendations.
Oh, okay.
And they recommend bone-specific therapy for any woman with a BMD score of negative 2.5 or lower.
Okay, so that makes sense.
Yeah.
That's kind of like the
The traditional cutoff
Yeah.
for osteoporosis.
osteoporosis, right?
Right.
And for all women over 65 with low bone mass.
Regardless of their T-score.
Okay, so those are the more straightforward cases.
Yes.
But what about the women under 65 with osteopenia
Right.
who aren't considered high risk by FRAX?
Right. That's the gray zone.
Yeah, that's a gray zone.
And the toolkit doesn't leave us hanging there.
Okay, good.
It brings in findings from the NORS study,
Okay.
which found that a peripheral BMD score of negative 1.8 or less was linked to an increased short-term fracture risk.
Okay, so even in
Even in the osteopenic range,
yeah.
that lower T-score is a red flag.
Interesting.
Yeah. And it was specifically in postmenopausal women over 50.
Okay.
So it's not just about the T-score itself, it's
Yeah.
also about, the menopausal status.
And they looked at other risk factors too, right?
They did. They found that a history of prior fractures, poor mobility, and overall poor health status were also independent risk factors.
So it's really about looking at the whole picture,
Exactly.
not just the BMD.
Not just the numbers.
The numbers, right. Okay, so we need to be thinking about this
Yes.
in the early postmenopausal years.
Absolutely.
More than we
More than we have been.
Yeah, more than we have been. Okay.
And I think, the toolkit highlights some data from a clinical trial that really drives this point home.
Okay.
They found a 6.9% cumulative fragility fracture incidence over 3 years.
Wow. That's
A lot. Yeah.
in a group of postmenopausal women.
And these women were...
They were not on estrogen therapy.
Okay.
They had an average femoral neck T-score of negative 1.84.
So still in that
Still in that osteopenic range.
osteopenic range.
And they were taking calcium and vitamin D supplements.
So they were doing the right things.
The things that we recommend.
Right.
And yet they still had...
And yet they still had that significant fracture risk.
Wow, that's kind of scary.
It is a little bit scary.
It is, yeah.
And I think it really emphasizes the need for more proactive measures.
Yeah, absolutely.
And speaking of proactive measures, we can't forget about hormone therapy.
Right. MHT?
MHT, exactly.
Okay.
So the toolkit highlights the findings of the WHI study,
Okay.
which showed that hormone therapy reduced both vertebral and non-vertebral fractures
Yep.
by 34%.
That's huge.
It's huge
Yeah.
in women over 50,
And that was regardless of their BMD.
regardless of their BMD or other risk factor.
So even if they had osteoporosis,
Even if they had osteoporosis,
They still are.
MHT still...
still helped
That's
help
really
their
cool.
bones.
Okay, so this is really
Yeah.
changing the way that I'm thinking about
I think it's
MHT, because I always thought of it as like,
symptom management.
yeah, symptom management, but
Yeah.
it's really about
It's about more than that.
protecting long-term health.
Exactly.
Okay. And to make things even more interesting, the toolkit also reminds us that bone loss actually accelerates after menopause,
Right.
which we know,
We know. Yeah.
but it's easy to forget.
It is easy to forget. And I
Yeah.
think what's also important to remember is that that rate of bone loss varies depending on
Ethnicity, BMI,
all these other factors.
all sorts of factors.
So we really need to be thinking about this.
Individualized.
Yeah, individualized approach.
To each patient.
Okay, so what does the toolkit
Yeah.
ultimately recommend?
So they propose a pragmatic approach.
Okay.
They suggest that we consider hormone therapy for fracture prevention
Okay.
in all patients with osteopenia before the age of 65.
So even if they don't meet
Even if they don't meet the FRAX criteria.
the FRAX criteria.
Right.
Okay.
And of course, taking into account their other risk factors.
Other risk factors. So it's
It's
really
individualized.
individualized. Yeah, not
All
just
right, just a blanket recommendation.
a blanket recommendation. Okay.
But they do provide some more specific guidelines as well.
Okay.
They suggest that we could use a peripheral or femoral neck T-score of Nemerty 1.8 or lower
Okay.
as a potential cutoff point.
So that's kind of like
That's the NRA,
the NORAS
the NORA study cutoff.
cutoff. Okay.
But again, they emphasize the importance of considering things like BMI and time since menopause.
Right. So it's not
It's
just
not just about the number.
the number. Okay, this is really helpful because it feels like we're moving towards
A more personalized approach.
a more personalized and proactive approach
Yeah.
to menopause management.
Absolutely.
It's not just about treating symptoms.
Right.
It's about preventing these long-term consequences
Exactly.
like fractures.
And I think the toolkit really equips us with the knowledge and tools to do that.
I agree. I think this has been a really great deep dive so far.
You've covered a lot of ground.
We have. We've
Yeah.
talked about, understanding the nuances of menopause.
Yeah.
How to diagnose it, exploring all these different treatment options.
Hormonal and non-hormonal.
Yeah. And now we've really gotten into
Fracture prevention,
fracture prevention.
which is so important.
So important.
Yeah.
And, I want to kind of circle back to something that we talked about
Yeah.
earlier about FREX and
Its limitations.
its limitations. Yeah.
Right.
Because I think the toolkit
Yeah.
really emphasizes how important it is to recognize those
Mhm.
limitations.
Especially in our younger patients.
Right.
FRAX was developed based on data from older women,
Right.
and so it may not be as accurate
In younger women.
younger women.
Okay. And so I think the toolkit leaves us with this question of how can we better personalize fracture risk assessment
Yes.
and MHT recommendations beyond just relying on FRAX?
Right. How do we really tailor our approach
Yeah.
to each patient's unique circumstances and preferences?
And I think that's
It's a great question.
it's a great question to think about.
You asked the million-dollar question, isn't it?
It is.
And I think, the toolkit really encourages us to be thinking critically about how we're currently assessing fracture risk
Yeah.
and, maybe moving away from this reliance on FRAX as the be-all, end-all.
Right. Because it's just one piece of the puzzle.
It is one piece of the puzzle.
Right.
And I think, this whole deep dive has really been about moving towards a more personalized model of care.
Absolutely.
It's about recognizing that each woman is an individual
Yeah.
and that there's no one-size-fits-all approach to menopause management.
And I think this toolkit really arms us with the information to do that,
I agree.
to provide that individualized care.
It's evidence-based, it's practical, and it really, gets to the heart of what we need to know to help our patients.
Yeah. And it goes beyond just the clinical aspects, too.
Absolutely.
It really emphasizes that patient-centered approach.
Yes.
The importance of shared decision-making
Right.
and really empowering women to make informed choices about their health.
Right. It's about giving them the information that they need
Yeah.
to make the decisions that are right for them.
And I think sometimes we forget about that.
Yeah, it's easy to get caught up in the science and
Yeah.
the guidelines and forget that there's a person on
Right.
the other side of that.
A person with feelings and preferences and
Exactly.
Yeah.
Well,
a whole life. Yeah. And so I think, this toolkit does a good job of kind of bringing us back to that.
I think so too.
Okay. Well, I think we've covered just about everything.
I think so.
Is there anything else that you wanted to add?
No, I
Yeah.
think we've really hit all the key points.
Yeah. This has been a really great discussion.
It has.
I've learned a lot,
Me too.
and I hope our listeners have too.
I hope so.
So for any of our colleagues who haven't had a chance to explore the 2023 Practitioners Toolkit for managing menopause.
Yes.
I highly encourage you to check it out.
It's an invaluable resource.
Absolutely.
Can really enhance your practice and help you provide the best possible care for your patients.
Well said.
So go check it out.
Yeah, go check it out. And on that note, I think it's time for us to wrap up this deep dive.
Okay.
Thank you so much for joining us.
It's been a pleasure.
And we hope you've gained some valuable knowledge and practical takeaways
Yes.
that you can apply in your practice.
Absolutely.
Until next time, keep those minds curious and keep seeking out knowledge, because that's how we
grow.
Yeah, that's how we grow, and that's how we provide the best possible care for our patients.
Absolutely.
All right, well, thanks again.
Thank you.